what their complaint is. And so my biggest teaching point always when I'm teaching musculoskeletal exams is do your same exam every single time in the same order, in the same way, no matter what they come in about. It's super easy to jump to something, oh, it hurts when I do this, so you jump to have them do that, and then you forget about other things, and that's how you miss stuff. So everything I do is always systematic in the same way every single time, no matter what joint. So I always do inspection, palpation, range of motion, strength, neurovasc, special tests. Those 6 things every single time, no matter what. So I start with inspection because if there's some obvious deformity, you don't want to be moving on it or like cranking on it or doing any of the other tests. You're going to be sending them to x-ray before you do anything else. So I always start with an inspection, and that's why. Then I start with palpation. Again, so whether it's knee, ankle, we have our certain locations that automatic x-ray, so then I palpate. And if there's anything that comes up there that's concerning, I'll send them to x-ray before I have them move the joint all over the place. Then I go to range of motion, obviously see how well they're moving, strength testing, the neurovasc, a little bit more important, urgent care, and my setting on the sidelines. When it comes to a knee, neurovasc, we had like a big knee injury that comes into urgent care, like a knee dislocation, time is of the essence to figure that out and get them definitive treatment. So I just in the habit of doing that every single time on every single patient. And then I do my special tests at the end. Questions so far? So I'll go run through it really slow, and then I'll do it faster to show how fast I can go through it. Okay, so volunteer patient. So we can start, so if they're able to weight bear inspection, I always start like as they walk over to the table, I'll just have them pause for a second, and I'll look, stand shoulder width apart, so it's a little bit wider. And then especially in our age range, this part's important because patellofemoral is so common. So I look at their feet, I look at their knees, how are they aligned? Is there anything jumping out at me right away that looks like an obvious thing that could be leading to their pain? Are they valgus, are they varus, that kind of stuff. So I start with that. So I just kind of, I'll look at their feet, how well of an arch do they, how much of an arch do they have? I'll look at the back, are they pronating, anything like that. Again, how are their knees aligned? Are they nice and anatomical, or do they have valgus formation or varus formation? So varus, bow leg, valgus, knock-kneed. And then I have them get up on the bed and lay down. So I do most of my exam with them laying. Which knee's not in here? Okay, we'll do that one next.
Okay.
Let's start on this side. So that you can see better. So again, inspection. Do you come up for it?
There's seats up here if you guys want.
So again, inspection, just looking for effusion versus swelling. So obviously there's multiple places you can have swelling in the knee. It can be in the bursa, so it can be suprapatellar, prepatellar, or it can be intra-articular or intra-articular spreading to the back for a Baker's cyst. So I'll just look. How swollen is their knee? Does it look like it's above? I'm feeling. Does the fluid feel like it's above the knee? Does it feel like it's over the kneecap? Does it feel like it's in the joint? I'll milk, make sure is there any fluid wave or anything when it comes to like an intra-articular swelling. And that's pretty much, again, if they're not able to weight bear, you can look for alignment again just by putting their legs together to see if they're varus valgus. But most people that we see will be able to put weight on their legs, so you can do it while they're standing, which is better. And then palpation. So again, I'll start right in this position. I typically just start with kneecap. Are they hurting at all when I'm moving their kneecap? I'm going to feel under the medial patellar facet, lateral patellar facet. Do they have any pain there? So again, looking for patellofemoral type stuff. Then I'll have them come up, and I'll usually start at the top and make my way down. So I'll feel the femoral condyles. I'm going to feel the quad tendon, see if they have any pain there. Come down to joint lines, lateral and medial. feel. I usually come all the way around, and then coming all the way around on the inside. I'll feel MCL, LCL. I'll feel fibular head as well, always when I'm doing this. And I'll feel posteriorly, so like I'll just feel like posterior medial corner and posterior lateral corner, which is hard to see, but essentially I just kind of take my fingers in. I push pretty hard too on all my exams, so when it hurts, if it hurts a lot, I usually will compare it to the other side just to make sure. I'll feel tibial plateau, pes anserine, and then patellar tendon. So I literally just like squeeze, just like I would like an Achilles tendon, so I'll squeeze patellar tendon. And tibial tuberosity. So that's pretty much my whole palpation without having to move. So then they're already in this position, so range of motion, I'll make sure extension. Again, usually I'll compare side to side just to make sure they can get to full extension. Some people will hyperextend a little bit, so even if it looks like they're straight, they may not be equal to the other side. Then flexion, so can they get up all the way? So inspection, palpation, range of motion, strength testing, especially, again, this is sports medicine sideline or urgent care, but straight leg raise, so come up to my hand, making sure they didn't completely blow out their patellar or quad tendon if it's like an acute injury. Pull your heel towards your butt for hamstring, and then I test to failure, so I really test when I'm doing strength and stuff, again, because I can usually beat everybody, and it just helps for that when it comes to like sports medicine stuff. You know, a strength test of just like here, hold against my hand and just doing a little bit probably isn't going to recreate their pain if it's more like a subtle thing that's been going on a while. So I push them hard when I'm testing them. Also with straightening your legs, so push out against my hand. So try to straighten your leg. So I will really just test them, and again, test side to side when things are hurting. So strength test, so again, inspection, palpation, range of motion, strength, neurovasc. So for the knee, I usually feel posterior tib pulse. So and that's all about getting your fingers wrapped around the artery and then where you can feel it. And then dorsalis pedis. Again, this is more important in urgent care if somebody comes in with an acute injury and a big swollen knee, just to make sure they didn't have a multi-ligament injury or dislocation. And then special tests, which is the big thing. So the one thing I really want to focus on today. So my special tests I do are Lachman every time, anterior posterior drawer, varus valgus stress testing the MCL, LCL, and then I'll typically do McMurray and bounce home for meniscus, plus and minus other things when I kind of have a differential in my mind at that point, but those are the ones I do every time. So I typically will start with Lachman. So again, you can just relax. So Lachman, number one important thing is getting them to relax. So it's hard sometimes because if they won't relax, you're not going to get a good endpoint. If their hamstrings are tight, it will give you like a false endpoint and you won't feel the good snap. So when you're doing a Lachman, I always kind of explain it to people that essentially you think of a rope that has a little bit of slack to it and you all of a sudden like pull it and you hit that snap of an end to the end point, and that is what you should feel with your Lachman. So that's when you know you hit and had a good solid endpoint for Lachman. You don't always feel it. Again, a lot of people, if they're having knee pain stuff, Berkeley students in general tend to be high stress and have a hard time relaxing. So it can be hard to know 100%, but that is what you want to try to feel for. So I'll usually just have people kind of roll hip out, or get them nice and loose. So jiggle knee a little bit, and then it's just a quick little, so you can feel when I hit that end point. So just quick little for the Lachman. And usually the patient can feel too when you hit it really well. If you're not sure, so if you're like, well, was I hitting an endpoint? Was that loose? I just compare to the other side. So if I have any concern about an ACL, I always do both sides no matter what, essentially. So start with my Lockman, and then while I'm sitting here, I'll just hold, I'll check the MCL. So I usually do both with slight flexion and straight always. So MCL should be tight, both with flexion and fully extended. And then LCL will come off the edge of the bed. LCL will have slight laxity when flexed. So you're gonna have just a little bit of play when the knee slightly flexed, and then it should be tight with knee extended. So if you're having any looseness, again, extended, it probably had a slight LCL injury if that's where the pain is. Again, compare side to side. So then once I'm already holding their knee, I'll put their foot down, bend them up, and then I'm gonna do my anterior posterior drawer. Tips for anterior posterior drawer for me, again, a lot of people just grab and start moving back and forth. I don't find that as helpful because it's hard to quantify how much are they moving, does this feel abnormal, like that kind of stuff. So what I usually do is I put the palms of my hands kind of across the upper part of the tibia and then wrap my fingers up over their tibial plateau and kind of right to the inferior part of the patella. And then when I'm pulling, you can feel how much you're translating the tibia underneath your fingers. So like it gives me at least a feel that I can compare side to side more of whether or not it's loose. So I feel pretty confident in my Lockman usually, so I'm not as big a fan of this for testing an ACL, but for PCLs, again, you can feel how much it's moving. Like you can even probably feel like you can push back a little bit and get that to translate posteriorly. And then you can look again for SAG for PCL as well. But that's how I like to be able to hold it so I can feel how much they're moving and everything. And it gives me easier way of comparing side to side, like is this moving more or not moving more. So meniscus tests. Meniscus can be super hard to test for and know whether your test, like, is this a positive test? Is this not a positive test? So I'll typically do, again, bounce home. So I'm literally just getting them loose and bouncing it home to see if they have pain, again, along the joint line. So it's not just pain in general, it's pain along the joint line. And then McMurray, I'll wrap my hand around getting along the joint lines. And then I come all the way up, and then it's the rotation, out, coming all the way straight. And then rotating the foot other way. And so what I'm feeling here is pain and or click, like a little clicking in the joint line. Like for you, your kneecap was clicking a little bit there. So that's where having your hand actually on the joint line will help you clarify, like, is this clicking coming from the kneecap, which is super common, or is this actually coming from the joint line itself? And that's my whole exam, typically. If I have other questions about, like, I'm not sure if that was a good enough meniscus exam, I'm still kind of thinking that, but I couldn't recreate their pain, I might do Thessley or Apley, which is having them lay on their stomach and like compressing down, so roll over real quick. So the one is going up like this and compressing down and rotating, and the other is, you can roll back over, and the other is doing a single leg squat and twisting. So really crank on it. Again, I don't do it very often. It's just if they have a very good story and I really haven't been able to tell yet, I'll kind of gradually make my way down the list, but you don't need to worry about that as much. You can, if you're to that point, you can always let me send them to me and I'll take a look at it. The other test that I will do at the end is if I haven't been able to fully figure out what's going on yet, And I still suspect patellofemoral, but I'm not 100% sure it's that versus like a meniscus or something, is I'll just have them do a single leg squat and watch for pelvis collapse and if that recreates their pain or not. So, but for you guys, I think just the initial stuff is the most important stuff. Question?
Any tips for someone who's really tiny hands and you're examining a football player?
I mean, yeah, even I can't get it on some of those guys, like some of the offensive linemen and stuff. It just, I'll try, yeah. So like I'll try and get like leg under and support. So like keeping nice firm pressure down and getting, and then it's all about like making sure you're pulling the right angle. So like you're not pulling like over this way or that way. Like you're making sure you're getting the alignment that you're coming straight anteriorly to do it. But again, then it's like a feel of, like I cannot typically get a snap when I'm doing this, but it's a feel for how loose they are more. So like for you, like I'm not getting a good snap, but like you can feel like I can't translate you super far forward. So, but it is, yeah, it's hard. So it's, and that's, again, that's where I'll use their history a little bit more. Like they had an acute injury, they felt a pop, they had immediate swelling within the first hour or two. Those are all things to me that this sounds like an ACL story versus like patellar dislocation. The differential is pretty small when it comes to acute injury with immediate swelling in the knee of ACL, patellar dislocation, fracture, other ligament tear. Meniscus usually has delayed swelling a little bit unless it's a huge tear, but so that essentially narrows it down for you anyway, and I'll have a pretty low threshold for getting an MRI in those cases. Any other questions so far?
Can you do that bounce one again?
Yeah, so it's really, bounce home is just literally hold them in extension, and it's literally just like doing a little lift and letting it bounce straight. So, and that can hurt with meniscus tears. For me, I do that just because patellofemoral is so common in our students. Like that shouldn't hurt with patellofemoral. So if that's hurting, that makes me think a little bit more meniscus. Because if you're doing McMurray, if they have patellofemoral, that's going to hurt too. Right. So if they have pain underneath their kneecap, every time you go to full flexion, if you're smashing the kneecap down, and so it's going to hurt. And so it's sometimes hard to clarify which one of those it exactly is, which again is okay. I mean, initial treatment's going to be physical therapy as long as they have 4-inch motion anyway. So.
What things when you were feeling underneath? What are you feeling? Like,
so like you can have, like if you have a posterior horn meniscus tear, sometimes their pain's actually more wrapped around the back. So if you're feeling the anterior joint line, if there are tears in the posterior part of their meniscus, they might not hurt at all there. Mm-hmm. So that's where I'll follow the joint all the way around the corner essentially. And so like I'm digging in all the way back and behind the knee, you can see. And then like you also have the insertion of your hamstring and the origin of the gastroc there, and lots of other little stuff that gets more complicated to diagnose and figure out. But again, as long as it helps kind of clarify for you like what your differential is. So essentially when I'm going through my exam, I'm doing a differential in my head the whole time and ruling things in out, and narrowing it down as I go. So, and that's why at the end I kind of will maybe add a thing or two, but for you guys, like I said, the other extra special tests aren't as important. So, any other questions so far?
You do it a little faster on the other
Yeah.
days?
Yep, we can do that. So we'll do a rapid fire like I would normally do.
And this is the bad knee, Allison?
This knee's hurting. I think it's patellofemoral.
Yeah. So again, if like I step in the room, I'll get my history stuff, And then as they're going up to the table, so I'll do my quick inspection if they're weight bearing. Then have them lay down, so inspection, so quick, make sure you get the knee visible. That's the other big thing with joints. Make sure you look at the joint, like uncover it. It can be, especially in primary care, if they don't get into gowns or like shorts and things, it's easy to not like fully like look at it, but you can see a lot of things like that. So inspection, again, looking, is there any effusion or anything? I always do kind of milking, just look for a subtle joint infusion. Good, palpation, so move the kneecap, so. Different than the other side, same as the other side. Not too bad. Okay, and up. So, yeah, I always do systematically when palpating. So I'll start up, move my way down. I do both sides at the same time and just say, does it hurt on the inside or outside? Again, wrapping around. Posterior medial, posterior lateral corners. Tibial plateau, patellar tendon. Good range of motion. And comparing side to side. Can't really do that at all. Good. So hold straight out. Good. Come over, touch my hand. Hold there. Good. Heel towards the butt. Good. Push out against my hand. Good. Do the same, both sides, pulses. Good, special tests. So this one here, a little tighter than the other side. There we go. And then MCL, so we have no flexion, straight. LCL coming around, so a little flexion. And straight. And anterior posterior drawer. Bounce home. And make one ready. You have a lot of crevice on your kneecap. That's bad.
Yeah.
So in her case, this is one where I would have her do single leg squat, plus minus. I might do patellar compression, but I find somebody whose knee's really hurting, if you do patellar compression, it just tends to hurt. And so like, you smash their kneecap down and they're like, oh, that doesn't feel good. And it's like, didn't do that. So go ahead and stand up once and we'll just see.
Yeah, I'm curious what you're looking for when you.
So I'll have them, so for that leg, I would have you stay on this side, and then I would have you just like fingertips
Yeah.
on there, and then just do single leg squat. So for you, you can see how much you're having pelvis collapse. Yep. So, and then I'll have you do like 4 or 5. And does that hurt? Or start feeling like it's hurting? Okay, not too bad. But for you,
I mean, I know I have.
yeah, it's health everyone. So like for her, there's some work to be done. Improving alignment and strength with her single leg squat. So you can just picture like for patellofemoral, if that's how their knees aligning every time they're going up and down the stairs, like your patella is not going to track very well and get irritated / irritate the patella tendon / any of the other stuff when it comes with patellofemoral syndrome. So that's usually a super easy patellofemoral test that, and I'm not having to flex a long ways, so it shouldn't hurt their meniscus too bad. They just need to go down a little bit. So I can get through. I don't know how long that took, but I can get through that pretty fast.